Today, I'm pleased to introduce Dr. Ami Shah, Director of Clinical and Translational Research at the Johns Hopkins Scleroderma Center and Associate Professor of Medicine at Johns Hopkins University School of Medicine. Dr. Shah completed medical school at Johns Hopkins University School of Medicine, trained in internal medicine at Stanford University, and completed rheumatology fellowship at Johns Hopkins. In addition to her medical degree, she obtained a Master of Health Science from Johns Hopkins Bloomberg School of Public Health. Dr. Shah is recognized as an expert in the clinical care of patients with systemic sclerosis, Raynaud's phenomenon, and fibrosing syndromes. She has given both national and international talks on her research focus, the relationship between scleroderma and malignancy, which we will hear more about today. Please join me in welcoming Dr. Shah.
Thank you. I'd like to thank everyone for the kind invitation to come visit with you and to talk about my research interests in scleroderma. These are my disclosures, none of which are pertinent to this talk, and here are some of the references that I'll be talking about. So my objectives today are to review the epidemiology of cancer and scleroderma with a specific focus on the temporal clustering of cancer diagnosis with the clinical onset of scleroderma and what that may tell us about the cancer-scleroderma relationship. I'll discuss distinct autoantibody subsets that may provide unique insights into the biology of the cancer-scleroderma relationship, and then suggest some implications this may have for developing an approach to targeted cancer screening in patients with this rheumatic disease. And I wanted to start out with a case who I saw as a rheumatology postdoctoral fellow that really generated our interest in this area. This was a 43-year-old woman who described that in April of 2006, she developed cold-induced pallor and violaceous discoloration of her fingers consistent with Raynaud's, and she had swelling of her hands and her face. And when she was undergoing a workup for these symptoms, she had a chest radiograph performed that demonstrated a mass, which when biopsied was consistent with a small cell carcinoma. She was treated with chemotherapy, radiation therapy, and prophylactic brain irradiation. And she described within a year that her Raynaud's had worsened in intensity and frequency, her hands were more swollen, and then she developed a really explosive onset of skin thickening involving her entire body. And the skin thickening was definitely worse in the radiation port in the anterior chest and scapular region of the back, but clearly extended well beyond this region. She was noted to be positive for anti-nuclear antibodies and negative for SCL70. And it was around this time that RNA polymerase III autoantibodies became commercially available for us to test for clinical use when seeing patients with scleroderma, and she was indeed anti-RNA polymerase III antibody positive. So when we saw her, we were really intrigued by this coincidence of cancer with the first clinical signs of scleroderma, and we asked ourselves, why is this patient experiencing both of these diseases together in time? Was this simply due to the increased risk of lung cancer that we know exists in patients with scleroderma? This seemed a little bit unusual to us in that we usually expect this to develop in patients with long-standing disease. They may have interstitial lung disease, and they develop a lung cancer in that context. We asked, is her skin thickening simply the effect of radiation-induced fibrosis? Again, this seemed a little unexpected for us. She already had swelling of her hands and face well before she was exposed to radiation therapy. And while she had skin thickening in the radiation port, it clearly extended well beyond the field of her radiation. And we asked, could cancer somehow be playing a role in the clinical expression of her scleroderma, and hypothesized, could tumor antigens somehow be provoking the immune system and resulting in the development of an autoimmune disease? Before I talk more about scleroderma and its relationship with cancer, I just wanted to take a step back and talk about scleroderma more broadly. This was well described by Sir William Osler as a shrinking skin of steel. And he said, in its more aggravated forms, diffuse scleroderma is one of the most terrible of all human ills, like Tithonus to wither slowly, and like him, beaten down and marred and wasted until one is literally a mummy, encased in an ever-shrinking, slowly contracting skin of steel, is a fate not pictured in any tragedy, ancient or modern. We know that scleroderma is actually a very heterogeneous rheumatic disease, but within that heterogeneity, there are very well-defined subtypes of scleroderma that exist that share common clinical links, but there are unique features, a unique disease course, and a unique expression within these subsets of patients with different potential outcomes. One of the ways that we phenotype our patients to better understand which complications they may be at risk for is by performing something called a modified Rodnan skin score, where we assess for dermal fibrosis in 17 different body areas. And when we're performing this score, we're not only trying to get a sense of the total severity of the disease, but to classify patients as to whether or not they have limited cutaneous systemic sclerosis or diffuse involvement. And that's shown here on this slide, where patients with limited scleroderma have skin thickening that's distal to the elbows or knees, and patients with diffuse scleroderma have more proximal limb involvement or truncal involvement. And we know that phenotyping patients in this way can be very helpful because patients with the most mildest form of limited scleroderma, the type 1 involvement, have a much lower risk of interstitial lung disease, whereas those with type 2 limited scleroderma have an intermediate risk, and those with type 3 or diffuse scleroderma have the highest risk. In addition, we know that patients with different cutaneous subtypes of scleroderma may have different risks of scleroderma internal organ complications, and that's shown here in a patient with diffuse scleroderma who has extensive skin thickening resulting in severe finger flexion contractures and interstitial lung disease. So this patient has more of a pro-fibrotic phenotype of their disease, whereas illustrated below is a gentleman with limited scleroderma who has extensive telangiectasia, severe Raynaud's phenomenon resulting in macrovascular digital loss and pulmonary hypertension, and this patient has more of the vasculopathic presentation of scleroderma. Even contained within this, there's a lot of heterogeneity. So there are some patients with limited scleroderma who have a very benign clinical course over time. There are others who have overlapped syndromes with Sjogren's syndrome or primary biliary cirrhosis. There's a subset of limited scleroderma patients who can develop very severe interstitial lung disease, and there may be a higher risk of pulmonary arterial hypertension. And similarly, among patients with diffuse scleroderma, there's a lot of variability where there are patients who can have a more benign course and those who can have a much more aggressive and rapid course with an increased risk of renal crisis and cardiomyopathy. One of the best tools that we have as rheumatologists to help us predict a patient's potential phenotype and trajectory over time is the use of scleroderma-specific autoantibodies. And the three most common autoantibodies that we see in these patients are anti-centromere, anti-topoisomerase 1, which is SCL70, and anti-RNA polymerase 3. And these three antibodies account for about 2/3 of all scleroderma patients. We know, for instance, that patients with anti-centromere antibodies are more likely to have a Crest syndrome phenotype. Those with topoisomerase 1 autoantibodies have a higher risk of interstitial lung disease, and those with RNA polymerase 3 antibodies, like the patient I described to you at the beginning, has a much higher risk of severe skin thickening and a much higher risk of scleroderma renal crisis. We know that autoantibodies can also be useful to predict survival. This is data from a Royal Free Hospital scleroderma cohort where they show that patients with topoisomerase 1 antibodies have much worse survival over time because of their higher risk of interstitial lung disease. So now coming back to this idea of scleroderma and whether it could be related to cancer, when we saw this patient in our center in 2007, we really didn't know a lot about the relationship between scleroderma and cancer. There had been a lot of epidemiologic studies demonstrating that there's an increased risk of cancer in patients with scleroderma with standardized incidence ratios ranging from 1.5 to 2.5. We knew in our cohort that approximately 12% of our patients had a history of cancer, and that malignancy was a major non-scleroderma cause of death. Interestingly, there had been these case series published of patients getting scleroderma and cancer together in time. And this had been reported most commonly for breast cancer, but had been described for an array of tumor types. And there had been these intriguing case reports of patients getting cancer and scleroderma together in time, receiving treatment for the cancer and having a dramatic improvement in the scleroderma. And this raised the question of whether or not cancer was a driver of the disease, or is it simply that these patients are receiving potent immunosuppression for their malignancy and their scleroderma is improving. Just to give you a flavor of the literature describing cancer risk in scleroderma, I've selected one meta-analysis to share with you. This was a study looking at 6 original studies with more than 6,000 scleroderma patients, and they calculated a pooled standardized incidence ratios for all cancers of 1.4 and found that there was an increased risk of lung, bladder, hematologic, liver, and non-melanoma skin cancers. The risk was higher in men, and it was higher in the first 12 months after a scleroderma diagnosis compared to more than 12 months after the diagnosis. There were no clear differences in cancer risk by whether somebody had limited or diffuse scleroderma, and no differences in lung cancer risk by smoking or interstitial lung disease status. Although these latter 2 points are a bit controversial, as other studies have suggested a higher risk of cancer in patients with diffuse scleroderma, and of lung cancer in particular in patients with ILD. Other potential risk factors for cancer in this patient population includes older age at the time that they're developing scleroderma, obviously prior immunosuppressive drug use, and concern for an increased risk of cancer in certain target organs that may be involved by the disease. So for instance, esophageal cancer in someone with severe GERD, or liver cancer in someone with an overlap with PBC. Other potential links between scleroderma and cancer include that cytotoxic immunotherapy or radiation treatments for cancer could predispose patients to developing scleroderma or scleroderma-like disease. And I've just illustrated this here in a patient who received gemcitabine chemotherapy and developed severe Raynaud's phenomenon with critical digital ischemia, and in another patient who, after radiation therapy, developed very exaggerated fibrosis in the radiation port, well beyond what you would typically expect for a late radiation toxicity. There could be a shared genetic susceptibility for cancer and autoimmunity, a common inciting exposure, or in a subset of patients, there could be perineoplastic disease. So for the remainder of this talk, I'm really going to focus on this last question of whether or not there are subsets of our patients who have cancer-induced autoimmunity. So after we had seen a few patients like the one I described to you in the beginning, we hypothesized that scleroderma-specific autoantibody production in a subset of our patients could be a manifestation to an immune response to tumor antigens that either associates with or induces the scleroderma disease process. And to do this initial study, we recruited scleroderma patients with cancer who had available sera and where we could retrieve their cancer tissue from wherever it was stored clinically for biological study. And we were specifically interested in this issue of temporality and the clustering of cancer with scleroderma. So in this initial study, there were 23 patients with scleroderma and cancer, and what I'm showing you here on the y-axis is how long somebody had scleroderma when they were diagnosed with cancer, where time 0 is the time of scleroderma onset. And on the x-axis, I'm showing you the different scleroderma autoantibodies, those who are positive for RNA polymerase III antibodies, topoisomerase I antibodies, and anti-centromere antibodies. And you can see that patients with scleroderma and RNA polymerase III antibodies had this tight clustering of cancer with the first clinical signs of scleroderma, and that this looked very different than patients with topo I or anti-centromere antibodies. I also want to draw your attention to this group here that's listed as autoantibody negative. These patients are negative for centromere, topo, and RNA polymerase III antibodies, but likely target other scleroderma autoantibodies of interest, and they may also have a similar clustering of cancer with the first clinical signs of scleroderma. So we were very surprised to see this cancer scleroderma clustering occur in a distinct autoantibody subset of patients with RNA polymerase III antibodies. And based on this, we investigated whether there were differences in RNA polymerase III antigen expression in cancerous tissues from these patients. So what I'm showing you here is a scleroderma patient with RNA polymerase III antibodies in ovarian cancer and a similar patient with breast cancer. And I think you can see here that there's increased nucleolar staining of RNA polymerase III in these patients' cancerous tissues that was not evident in normal tissues and also was not evident in cancerous tissues from patients with other scleroderma autoantibodies. So these data suggested to us that cancerous autoantigen expression and scleroderma-specific immune responses may be associated. After this initial study, there was a lot of interest in this in the rheumatology community, and multiple scleroderma cohorts looked at this further and confirmed that indeed patients with RNA polymerase III autoantibodies have a much higher risk of cancer at the time that scleroderma is developing compared to scleroderma patients who are negative for these autoantibodies. So in these different cohorts, it was found that these patients may have a 4 to 6-fold higher risk of cancer within a few years of scleroderma developing. We also looked in our much larger scleroderma cohort. This was in over 1,000 patients who had complete autoantibody data, 16% of whom had cancer. And what I'm showing you in this graph here is the time that scleroderma is developing, and you can see that there's a clustering of cancer cases in particular within a few years of scleroderma onset. We were interested in trying to identify risk factors for cancer overall or cancer-associated scleroderma. And while RNA polymerase III autoantibodies are not predictive of long-term cancer risk, they do associate with a higher risk of cancer within 2 years of scleroderma onset. Here, a 5-fold increased risk compared to scleroderma patients who are negative for these autoantibodies. We really didn't see any other factors that were significantly associated with a higher risk of cancer beyond an older age of scleroderma onset. White race was predictive in this one model, but that was due to non-melanoma skin cancers, and once these were excluded, race was no longer a significant factor. We didn't find any relationship between specific internal organ damage, disease severity, or immunosuppressive therapy and cancer risk. This is just looking at that issue of clustering in a slightly different way. So here on the y-axis of this graph, I'm showing you the age of cancer diagnosis, and the x-axis, the age at scleroderma onset. And this is subsetted by different autoantibody groups. And in each graph, the red line is the 45-degree line of perfect agreement, where these two diseases are occurring together in time. And I think you can see that patients with RNA polymerase III antibodies are clustering tightly along the line of perfect agreement, and this looks different than the other autoantibody subgroups. So based on these initial epidemiologic studies, we asked whether or not this simultaneous scleroderma and cancer presentation, plus this highly specific immune response to RNA polymerase III, does it provide any opportunity to understand a mechanistic relationship between cancer and scleroderma? And this was work that was led by Anthony Rosen, Ken Kinsler, and Bert Vogelstein at Johns Hopkins. We studied 16 scleroderma patients with cancer who had adequate quality cancer tissue to enable genetic sequencing. 8 of these patients were positive for RNA polymerase III antibodies, and 8 of the patients were positive for anti-topo or anti-centromere antibodies. And you'll see that the patients with RNA polymerase III antibodies had a fairly short cancer scleroderma interval, with many of them having cancer shortly preceding the first clinical signs of scleroderma. So here, negative values denotes that cancer is coming first. And this looks very different than the anti-topo and anti-centromere groups in general. There are a few short interval cancers here in this subgroup, but not quite the same distribution that we see for RNA polymerase III positive patients. The next thing I'd like to draw your attention to is that there's a significant amount of breast cancer that we're seeing in these patients. So when Bert and Ken's group sequenced these patients' tissues, they identified that 3 of the 8 patients with RNA polymerase III autoantibodies had evidence of somatic mutations at the POLR3A locus that encodes for RNA polymerase III in their cancerous tissues. This was not evident in the patients with anti-topo or anti-centromere antibodies. In addition, 5 of these 8 patients had evidence of loss of heterozygosity at the POLR3A locus. So in total, 6 of the 8 patients had some type of genetic abnormality at the POLR3A locus in their cancers, which was not seen in patients with anti-topo or anti-centromere antibodies, and is not seen commonly in cancers in general from patients without scleroderma. 2 of these 3 patients who had a somatic mutation at the POLR3A locus had evidence of mutation in wild-type peptide-specific CD4 positive T cells, and all 3 of these patients had autoantibodies to RNA polymerase III that recognized both the wild-type and the mutated form of the protein. So these data suggested to us the following conceptual model, which is that in developing cancers, if there's a mutation in an autoantigen, this could potentially induce an anti-tumor immune response that is specific to the mutation. However, if this spreads to the unmutated autoantigen, additional anti-cancer effects may result, but this may lay the groundwork for the development of autoimmunity. Now, there are limited data on whether scleroderma autoantigens are highly expressed in tissues that are targets of the immune response, but we know from other paraneoplastic autoimmune syndromes that autoantigens can be highly expressed in cancers, as well as in target tissues. And some examples of this are in dermatomyositis, in the paraneoplastic neurodegenerative syndromes, and in melanoma in patients who develop vitiligo. And I just want to give you an example from dermatomyositis. So this was work that was done by Olivia Cassiola-Rosen at Johns Hopkins, where she was looking at a myositis autoantigen called MI2. And she found that MI2 was highly expressed in breast and lung cancers, as well as in dermatomyositis muscle, particularly in diseased muscle that was undergoing repair and regeneration in immature myoblasts. So again, this suggests the possibility that an anti-tumor immune response that then spreads may lay the groundwork for the development of autoimmunity. Based on these initial data, many people were asking us, are these autoantibodies cancer biomarkers independent of rheumatic disease? And we did a small pilot study looking at 50 breast cancer patients and 50 age-matched at-risk controls, all of whom did not have rheumatic disease, and looked to see whether or not this RNA polymerase III antibody, but also some antibodies that are relevant in cancer-associated myositis called NXP2 and TIF1 gamma, whether or not they were present in these patients. And there were no cases or controls with moderate to strong autoantibody positivity. So these initial data suggest to us that these autoantibodies may be markers of a higher risk of cancer in patients with these rheumatic diseases, but may not be cancer biomarkers more broadly. Now, I mentioned to you before that patients with RNA polymerase III antibodies have a higher risk of cancer around the time that scleroderma is developing. But what was interesting to us is there's this other group here of patients who are negative for centromere topo and RNA polymerase III antibodies, who also may have clustering of cancer with the first clinical signs of scleroderma. And this group is actually a very heterogeneous subgroup that likely contains many other subgroups within it of patients targeting different immune responses. So we're interested in identifying, are there other autoantibodies within this subgroup that associate with a higher risk of cancer? So to do this study, we collaborated with Steve Elledge and George Zhu at Harvard, and did a small study looking at 16 patients who are negative for these three antibodies, centromere topo and RNA polymerase III, but all of whom had a fairly short interval between their cancer and scleroderma. And Steve has pioneered the use of this technique called phage immunoprecipitation sequencing, or FIPSeq, as a way to identify the antigen targets of serum autoantibodies. So Steve and George identified that 4 of these 16 patients who were negative for these big 3 classical scleroderma autoantibodies targeted a molecule called RNPC3, and this was subsequently validated by IVTTIP. RNPC3 is a member of the minor spliceosome complex, and it participates in the removal of U12 type introns from pre-mRNA, and it's also known as U11, U12. And this has been described as being present in scleroderma patients once before from the University of Pittsburgh scleroderma cohort, and it in particular associates with a very high risk of severe interstitial lung disease. So we interrogated our much larger cohort of scleroderma patients with cancer, over 300 patients, and assayed for these autoantibodies, and confirmed that indeed patients with RNPC3 antibodies do have a short cancer scleroderma interval that's similar to patients with RNA polymerase III antibodies. These patients tend to be older at scleroderma onset, and they tend to have aggressive disease. So I mentioned to you that patients with RNA polymerase III antibodies have very severe diffuse skin involvement. These patients tend to have more severe interstitial lung disease. And relative to patients with anti-centromere antibodies, both of these antibody subgroups have a more than 4-fold increased risk of cancer within a couple of years of scleroderma onset. And again, that's just showing you the data graphically, where you can see that the patients with RNPC3 antibodies are clustering along this 45-degree line of perfect agreement. We interrogated whether or not there were clinical features that could help us predict whether somebody would actually get a cancer if they had an autoantibody. So we have to keep in mind that even if someone has RNA polymerase III antibodies, only 20% of these patients have an underlying cancer. But thus far, we haven't identified any phenotypic features that predict who will get a cancer but we have noticed that there is, in particular, an enrichment of breast cancer cases in both of these antibody subsets. So one of the questions for me as a clinician is if cancer could be a trigger for scleroderma in patients with these autoantibodies, how should we actually screen for cancer in patients with new onset scleroderma if they're positive for one of these markers? And is cancer therapy effective scleroderma therapy? And to get at this point, I just wanted to share one case with you that was recently published in the literature that was intriguing and suggests that treating the underlying malignancy could be an effective treatment of the rheumatic disease. So this is a 43-year-old woman who had diffuse scleroderma and polymyositis, and she was positive for anti-PMSCL antibodies, which is another marker that people are interested in the scleroderma cancer relationship. And she was found to have a solid pseudopapillary pancreatic neoplasm. And this group of investigators looked at expression of PMSCL 100 in the patient's cancerous tissue and confirmed that there was indeed increased nuclear expression of PMSCL 100 in the cancer. In this case, the patient's cancer was surgically resected. She didn't receive chemotherapy, so there was no other potent immunosuppressive therapy that was put on beyond what she had been getting for her overlap syndrome. And in her case, after the cancer was resected, they were able to rapidly wean off of all of her immunosuppression, and she had resolution of her skin thickening and myositis. So again, this raises the question of whether or not removing this potential antigenic stimulus, whether that was sufficient to treat the underlying rheumatic disease. So as a clinician, my interest is in developing clinically actionable metrics that can help guide and inform who we should be screening for cancer, when, and for what tumor types, and how do we treat these diseases when they coexist. And after this initial data came out, people in the rheumatology community were asking, should I be doing whole body PET CT in these patients? Should we be screening these patients for cancer like we sometimes do in patients with new onset dermatomyositis, which is often a much more structured and aggressive screening regimen? And I've had some reluctance in recommending that because I'm worried about overdiagnosis and the harms of over-testing these patients based on the available data. So we've recommended age and sex-based cancer screening and then risk factor-based cancer screening. And I've just given a few examples here of things, for instance, in our patients with ILD, doing a high-resolution chest CT, or if someone has oropharyngeal dysphagia, which we can see in scleroderma, if they don't have pharyngeal muscle weakness, maybe they have a tongue cancer, because we know that there's a higher risk of tongue cancer in scleroderma. But the question really is, should we be doing a pan scan in these patients or a whole body PET CT? There have been some recommendations generated by a European scleroderma consortium that indeed these patients should undergo screening, but again, it's really been based on kind of age and sex-based cancer screening. So as we were thinking about this question, we went back and looked at our Scleroderma Center database, where we've captured data on over 3,500 scleroderma patients, and we asked ourselves, what kinds of cancers are we seeing in these patients? And I mentioned to you at the beginning this meta-analysis that demonstrated that there's a higher risk of lung, hematologic, liver, and bladder cancers in these patients, but you can see the absolute numbers of cancer cases is actually fairly small when you think about the overall denominator. The three most common cancers we see in our cohort are breast, lung, and skin. These account for 2/3 of all cancers. So as we think about an approach to cancer screening, we need to factor this in. And so the question is, can we use autoantibodies as tools for cancer risk stratification, not just for target organ involvement stratification, with a specific focus on some of these autoantibodies that we've detected as potentially being associated with cancer to date. So to do this study, I partnered with Tak Agusa. Tak is a civil engineer at Johns Hopkins in the School of Engineering, and he and I had been working on developing a mathematical model to describe the relationship between cancer, the immune system, and the development of autoimmunity. And we talked about how this was a big clinical problem and designed a study to compare cancer incidence in our cohort to the general population using the SEER Cancer Registry. And we were interested in whether or not overall and site-specific cancer risk differs by the type of autoantibody that someone has, based on the type of scleroderma they have, limited or diffuse, and based on this issue of timing. And so I just wanted to walk you through a little bit of the data from that study that included over 2,000 scleroderma patients. So let me just walk you through a few of the graphs here so you can get a sense of the kind of data that we're able to generate. So in this top graph here, this is a graph that's looking at the numbers of cancer cases that we're seeing in our patients develop over time. Time 0 in this graph is when somebody is developing scleroderma. And the blue line is showing you the numbers of cancer cases that we're observing in our cohort over time. And the red line is showing the number that would be expected once you adjust for age, sex, race, calendar year, etc., based on the SEER data. The second graph is showing you the ratio of this observed to expected as a standardized incidence ratio. And the bottom graph is showing you the cumulative incidence of cancer over time in our cohort in blue with what would be expected based on the data in the SEER Cancer Registry. So when you look in the entire scleroderma cohort, you don't see much of a signal. But what happens when you layer in autoantibody as a filter through which you look at the cancer-scleroderma relationship? So here we see for patients with RNA polymerase III antibodies that they have many more cancers observed than expected around the time of scleroderma onset, with a higher standardized incidence ratio and a higher cumulative incidence of cancer over time. And similarly, patients who are negative for centromere topo and RNA polymerase III antibodies but likely target other autoantigens of interest, these patients have a higher standardized incidence ratio of cancer at the time of scleroderma onset. When you look at the other common scleroderma antibodies, so here topoisomerase I and anticentromere, different patterns emerge. So we see that patients with topoisomerase I antibodies have a risk of cancer that's very similar to the background risk in the general population. But really surprisingly, patients with anticentromere antibodies have a much lower risk of cancer than what you would expect in the general population. Here shown with far fewer cancer cases observed than expected, a lower SIR, and a lower cumulative incidence of cancer over time. And then if you ask how can this actually impact screening, we can see that within 3 years of scleroderma onset, patients with these RNA polymerase III antibodies have a 2.8-fold increased risk of cancer. But depending on the type of skin involvement pattern they have, they may be at risk for different types of cancer. So patients with RNA polymerase III antibodies and diffuse scleroderma have a higher risk of breast cancer, prostate cancer, and tongue cancer, and those with the limited form of scleroderma have a higher risk of lung cancer. And we can generate similar findings for the CTP negative subgroup of patients, showing there's a higher risk of breast cancer, melanoma, and tongue cancer. So this may lay the groundwork for us to develop a targeted cancer screening algorithm in these patients. The number of patients you'd have to screen with RNA polymerase III antibodies to detect one cancer is about 11, so it's not particularly high. And the question is this magnitude of cancer risk, especially breast cancer risk, high enough to justify doing breast MRI in these patients, as you would do in a patient who may be at higher risk for breast cancer in general, usually with mammography alternating with MRI at 6-month intervals. So further studies are underway to define some of this. It's intriguing to us that patients with this same autoantibody may have a different type of scleroderma that associates with different types of cancer. So for instance, why is it that patients with RNA polymerase III antibodies and diffuse scleroderma have a higher risk of breast cancer, whereas those with RNA polymerase III antibodies and limited scleroderma have a higher risk of lung cancer? And one question is, does the type of cancer result in different alterations of the autoantigen, and does that change the immune response and the clinical manifestation of the scleroderma that we see? And I think the big surprise for us from this work was the decreased risk of cancer in patients with anticentromere antibodies. It's intriguing to think about this as to whether or not anticentromere could actually be a potent anti-tumor immune response. Could it actually be harnessed in some way for cancer therapy? It's important to note that patients with anticentromere antibodies have more of a vasculopathic phenotype of their scleroderma. They have more telangiectasia, they have more pulmonary hypertension. They have this anti-angiogenesis program. And so the question is that actually very effective in keeping cancers from growing as well? So to summarize, we've demonstrated that there's a temporal clustering between cancer and the onset of scleroderma among patients with RNA polymerase III and anti-RNPC3 antibodies. And there are some compelling biologic data that are emerging not only in scleroderma, but also in dermatomyositis that suggest that there may be a model of cancer-induced autoimmunity in some of our patients with rheumatic diseases. There are likely many other markers of an underlying malignancy, and there's a lot of work that's underway in both of these diseases to define these patient subsets. And autoantibody and phenotypic subsets may define cancer risk and type in scleroderma and lay the groundwork for study of a rational approach to cancer screening in these patients. There's a lot of work that's underway to better define the biology of this relationship, both in terms of identifying novel autoantibody markers that associate with cancer, but also genetic sequencing of some of these cancerous tissues and these other autoantibody subsets to see if the similar mechanisms that we identified for RNA polymerase III apply to these patients. And we're very interested in whether or not certain scleroderma immune responses are actually protective from cancer and what are the functional effects of these autoantibodies and whether or not they could be harnessed for cancer therapy. As a clinician, I'm interested in developing and testing an evidence-based approach to how we should screen for cancer in these patients, in particular with the question of whether somebody has relatively new onset rheumatic disease. If we detect an underlying cancer and treat it, can that effectively treat the scleroderma? And so with that, I'd like to thank you all for the invitation to come visit and for your time. I just wanted to acknowledge that the work I described to you is the work of our entire division of rheumatology, with a special thanks to Anthony Rosen, Livia Cassiolorz, Fred Wigley, and Laura Hummers, who have been incredible mentors and partners in this work. And with that, I'd be happy to take your questions.
Thank you, Dr. Shah, for the very interesting grand rounds and your findings on antibodies. I was wondering whether or not there's any, if you have a feeling whether there's genetic or epigenetic in this era of precision medicine factors that may really be overwhelmingly responsible for some of these cancer phenotypes, that the antibodies themselves are just the tip of the iceberg.
I think it's certainly possible. I mean, some of the genetic changes that we're detecting in the cancers raise the question of whether or not that is the underlying stimulus that's setting the process in motion, but there's a lot of study underway to better define that. Yes? Mm-hmm.
Also whether these mutations are also unique to the tumor?
They're unique to the tumor. And at least in the 3 patients who had those somatic mutations, the mutation was different in each of the 3 patients. The autoantibodies that we're seeing are cross-reactive to both the mutated form of the protein and the wild-type protein. There were.
Repeat the question.
Yes, there were CD4 positive and CD8 positive T-cell immune responses that were responding to the mutated form of the protein. Was that your question? Yes.
Dr. Contreras?
Yeah, is there any model where if you overexpress this protein, you get cancer?
That's a great question. So people have asked us, do we have a mouse model that we're studying this in? And the answer is we don't. So I'm not aware of that. If you look back in the COSMIC database, for instance, at other cancers, we don't find that these kinds of mutations are highly present in cancers in general. So this is really what we've been able to find in patients who have this specific immune response, that they have evidence of an underlying alteration of the autoantigen. There's been similar data in dermatomyositis. So in dermatomyositis, there are 2 autoantibodies that have been found that account for more than 80% of the cancer-associated myositis cases, and that's TIF1 gamma and NXP2. And there was recently an abstract at our American College of Rheumatology meeting describing mutations in TIF1 gamma in cancers in patients who have cancer-associated myositis, again, raising the question of the same conceptual model.
Yes.
Was there increases of scleroderma in patients that are undergoing checkpoint inhibition?
It's a great question. So we've actually been building a program to study rheumatic immune-related adverse events from patients who are getting immune checkpoint inhibitors because we're seeing more of these patients getting referred to us. I haven't seen any scleroderma cases develop de novo after immune checkpoint inhibition. There have been 2 reports that came out of the Mayo Clinic of scleroderma-like disease developing after immune checkpoint inhibitors. Most of what we've been seeing has been inflammatory arthritis. So we've seen a fair amount of RA-like disease, spondyloarthritis-like disease, and reactive arthritis developing in these patients. There have been reports of myositis developing, of single organ lupus manifestations. So we're certainly kind of at the tip of the iceberg of seeing these rheumatology cases of checkpoint inhibitor-induced disease. Yes.
As you know, the cause of scleroderma renal crisis remains undetermined, but there's been this fascinating association between RNA polymerase III antibodies and an increased risk.
Yes.
If you distinguish between RNA pol-3 patients who have cancer versus those that don't, is the risk of scleroderma renal crisis the same?
We've looked and we've tried to say myopathy, GAVE, all of these other things that associate with RNA polymerase III antibodies, or the severity of skin disease, is there a difference? And we haven't seen those differences. And whether we're simply underpowered to do that, I don't know. But I haven't seen a difference in the prevalence of renal crisis between the patients who get cancer versus those who don't.
Dr. Glassberg?
So the loss of heterozygosity rate is very interesting. A lot of the interstitial lung disease, for a variety of different genes, have loss of heterozygosity. Do you have insight into the second hit? You're working with a group that has done so much on second hit.
Yeah.
I want to ask you about hematopoietic stem cell transplants and tie it into the LOH.
Yeah. So
The epigenetic component.
Yeah, I think that ties into the Do you have ideas? Because it doesn't. You mentioned that it's not smoking.
right. Well, again, it's a little hard to know. I mean, I think smoking is an effect modifier in this whole scenario. And if you think about at least the lung cancer and tongue cancer associations that we're seeing, that may be playing a big role. I don't have more insight into what the second hit is. It's something that we're very interested in, but I wish I could say that in a more refined way or comment on that. But you were going to say about stem cell transplant.
And the next one is just to address
Yeah.
the recent data on hematopoietic stem cell transplants, not mesenchymal, although there is a group in Chicago looking at it, but obviously the hematopoietic stuff has been published.
Right.
And that ties in really well to what you're doing.
Right. So there have been a couple of big trials that have been done looking at stem cell transplant and scleroderma, one out of Europe and one out of the United States. The Scott trial was just published in the New England Journal of Medicine, so some of you may have seen it. It's interesting. It's a little hard to know how to interpret the trials for a couple of different reasons, in that the inclusion criteria were very different between the 2 trials. The U.S. trial had big problems with recruitment, and so their sample size was fairly small, and then in the end they changed the outcome measure to something that was a little bit difficult to interpret. So with all of those caveats, I think that there's a lot of interest in whether this is an appropriate therapy and in whom it might be an appropriate therapy. And I think the patients with RNA polymerase III antibodies who have this really aggressive, explosive onset to their disease may actually be the right type of candidate for that therapy. And it's intriguing to think about that in somebody who may have cancer-induced disease. Does that answer your question?
Yeah, I think you're right. I think there's a real problem with the U.S. side of the study.
Dr.
Yeah.
Shah, oh, sorry.
I'm sorry. I was just going to say, there's this move towards doing haplo transplants, and so there's a lot of interest in studying that in our center, and so maybe there will be more data to come.
Thank you, Dr. Shah.
Thank you.
Nice to meet you, and thank you for coming.
Thank you.
Well, and even if it